Welcome to the Gus Alva Perspective, a podcast that is set up to address different neuropsychiatric themes. I am delighted that once again, Dr. Jonathan Meyer is joining me to address one of the particular topics that he will be chairing at the Southern California Psychiatry meeting. This particular session will be looking at tardive dyskinesia and improving its overall management. When we tackle complex care with targeted treatments, that oftentimes gets us to the end goal that we are seeking. Jonathan, can you share with us some of the particular areas that you're excited about with this particular session?
As we've had two agents now approved for tardive dyskinesia in the United States in 2017, I think our focus has shifted over the years. It used to be on teaching people how to do the aims and maybe differentiating TD from drug-induced Parkinsonism, which is still important. But now more and more, we're really trying to educate everyone out there about talking to people regarding their tardive dyskinesia, getting them on treatment, and most importantly, as part of that conversation, recognizing the huge psychosocial impacts of TD. It's not just a movement disorder, it's a disorder of people. And for many individuals with tardive dyskinesia, yes, they may have physical manifestations, but the biggest impact on their life is from a psychosocial perspective. Imagine us, Gus. We could not do our job if we had even mild TD. It was involving somehow our face. People would look at us, it would interfere with our lives. For many individuals living with TD, this becomes a huge problem. And it leads people to sometimes some bad decisions, like, should I stop my medication, which has kept me stable, in order to manage my tardive dyskinesia? So I'm excited for people to come to this. I think you'll hear about new ways to rate the functional impact of TD beyond just the motor symptoms with aims, and also really learn a little bit more about these medicines. And I think the most important aspect is you don't have to change anyone's treatment to use a VMAT2 inhibitor to manage their tardive dyskinesia.
You're so right, Jonathan. And I love the fact that you just threw in so many different, rich, intertwining points that sometimes pop out. I think that for the clinician, the more challenging situation is when you see drug-induced Parkinsonism in conjunction with tardive dyskinesia, which certainly could coexist, and what to do. And I think that one of the nice things about the practicality tied in with the session that you'll be chairing is that we'll have an opportunity of illustrating that point. The other really beautiful area that you just brought into is the impact that it has on people, whether it be with their leisure activities, vocationally, physically, emotionally, psychiatrically. And you're right, 1 out of 5 people start becoming advocates for the wrong thing to do, and that is counseling people to not take their medicine, which is exactly what we're hoping doesn't happen. So yeah, I love the points that you brought about. You're right also that there's 2 therapies that are available. It's not a bad idea to understand the nuances associated with each one, and then subsequently just take into consideration that there's a great degree of heterogeneity in this patient population. Any other points that pop out, Jonathan, that you think would be worthwhile in whetting the appetite of our audience out there?
Well, for one thing, you talked about complex cases. How do you approach it when somebody has DIP and TD at the same time? And I think another theme kind of embedded in that is, what do you do with the people who are on anticholinergics, often inappropriately? We know anticholinergics are not a treatment for tardive dyskinesia, and they tend to make it worse. And the question is, what do I do with these medications as I'm trying to treat somebody with a VMAT2 inhibitor for their tardive dyskinesia? It's important to think through the problem, to understand who your patient is. And I think lastly, more than anything, when you make the decision to taper off anticholinergics, to be patient and do it slowly, just like you're tapering off a benzodiazepine.
What a phenomenal pearl, Jonathan. That is excellent because, just like the first session that you're actually going to be, again, spearheading the entire conference through, of really talking about, what happens with a new therapy that's more cholinergically driven. I think that particular pursuit is helping us reframe along the lines of the different medicines that we've initiated and then just allowed to kind of continue without really thinking through the consequences of what that evokes. And you're absolutely right. Anticholinergics, I think, is a great area of deep prescribing, or again, economizing on their utilization, but it's only done so through appropriate education. So I'm so happy that you're actually going to be leading the charge in helping the clinicians that make it out to the conference to really have the guidance and the appropriate scope as to how to go about doing this.
Well, I'm really excited about it. I think there's always more to learn. I think one thing we appreciate is TD is under-recognized and is undertreated, and we hope we'll give you the tools not only to use the VMAT2 inhibitors, but to engage in an ongoing conversation with people about trying to manage their TD in a way that doesn't destabilize the psychiatric progress they've made.
I love it. Can't wait. Thank you, Jonathan.